Hello, my name is Vikash. I am intern at Jacobi Medical Center, Albert Einstein College of Medicine, New York City. First of all, I would like to thank South Asian IBD Alliance, IBDClub, especially Dr. Ali, Ms. Tina, for providing me a platform to talk about recently published article in American Journal of Gastroenterology by Dr. Kappelman in IBDClub about real-world evidence comparing Vedolizumab and Ustekinumab in anti-tumor necrosis factor experienced patients with Crohn's disease. Here is the list of authors and reference to the article. I have no conflict of interest to declare. So, with regards to introduction, anti-tumor necrosis factor therapy is generally considered first-line treatment for moderate to severe Crohn's disease. Many patients with Crohn's disease lose response or become intolerant to anti-TNF therapy and subsequently switch out of the class. Additional treatment options include Vedolizumab, which is anti-alpha-4 beta-7 integrin antibody, and Ustekinumab, which is an anti-interleukin 12 and interleukin 23 antibody. Because anti-TNF refractory patients respond less well to subsequent treatment options, hence selecting the most effective second-line agent is critical. Objective of this study is to compare the effectiveness and safety of Ustekinumab to Vedolizumab in a large, geographically diverse US population of TNF-experienced patients with Crohn's disease. So here we discuss the methods. With regards to study design, it is retrospective cohort study which employed longitudinal claims from large US insurer, which is Anthem. With regards to data source, the study employed outpatient pharmacy dispensing data, outpatient medication administration, diagnosis and procedures from inpatient and outpatient healthcare encounters, and demographic and enrollment information for commercially insured individuals. So with regards to study population in this article, 885 new users of Ustekinumab and 490 new users of Vedolizumab were included. Inclusion criteria: at least 18 years of age at the date of cohort entry, continuous enrollment in health plan with medical and drug benefits during the baseline period, which is a period without evidence of either study drug in last 183 days. Moreover, at least 2 ICD-10 codes for Crohn's disease and at least 1 dispensing or administration of anti-TNF in the baseline period. Furthermore, includes individuals newly initiating Ustekinumab or Vedolizumab 6 months after the FDA approval for Crohn's disease. The exclusion criteria included 2 or more ICD-10 codes for ulcerative colitis in any care setting in the baseline period, and initiation of both drugs on the index date. So with regards to the outcome of interest, authors focused on effectiveness and safety. Primary measure of effectiveness was the treatment persistence beyond 52 weeks, which was defined by evidence of 1 or more than 1 dispensing or administration of the index drug 365 to 455 days after the index date. Secondary measures of effectiveness was all-cause hospitalization, hospitalization for Crohn's disease with surgery, which was related to the Crohn's disease, hospitalization for Crohn's disease without surgery, and hospitalization for infection. With regards to the safety outcome, primary measure was hospitalization for any infection, any malignancy, cardiac event, or thromboembolic events. So here we can see the baseline characteristics in this study population before and after trimming and prosperity score fine stratification. Before the prosperity score adjustment, there was slight female predominance in both treatment groups. As you can see, by the green arrow. Most of the study population had evidence of experiencing single anti-TNF agent in their available history before the entry into the cohort, as you can see by the yellow arrow. Going forward, 28% of Ustekinumab initiators versus 25% of Vedolizumab initiators had experienced with 2 or more unique anti-TNF agents in their history, as you can see by the green rectangle. As you can see in this histogram, after trimming and prosperity score fine stratification, Ustekinumab and Vedolizumab initiators seemed balanced on measured baseline characteristics and had overlapping prosperity score distribution. For the statistical analysis, prosperity score fine stratification was used to control the confounding. All the analyses were conducted using Sentinel prosperity score analysis tool. For the primary outcome of treatment persistence, author estimated risk ratios and 95% confidence interval. For the secondary outcome of effectiveness and safety, authors estimated hazard ratio and 95% confidence interval. Because the cohort used to evaluate our primary measure of treatment persistence, which required health plan enrollment for 15 months after the index treatment initiation, authors evaluated potential selection bias by conducting a sensitivity analysis specifying treatment discontinuation as a measure of treatment ineffectiveness. So here we are discussing the results. Here we can see the relative risk of treatment persistence beyond 1 year in Ustekinumab versus Vedolizumab initiators, stratified by demographic factors and prior treatment. So with regards to the primary analyses, among 884 new users of Ustekinumab, 404 showed persistence beyond 52 weeks, and among 484 new users of Vedolizumab, 205 showed persistence beyond 52 weeks. Overall, there was no difference observed in primary outcome of treatment persistence, with adjusted relative risk of 1.09 with 95% confidence interval crossing the null value. Authors also performed several pre-specified subgroup analyses stratified by age group, gender, recent immunosuppressive therapy, number of unique anti-TNF therapies. As seen here, there was no evidence of variation of treatment effect by any of these factors. So shifting the gears to the secondary analysis, the study identified 1,217 new users of Ustekinumab and 667 new users of Vedolizumab who made the eligibility criteria. Overall, this cohort showed similar baseline characteristics as the primary cohort and were well balanced after the prosperity score trimming and weighing. So Ustekinumab was associated with the lower rate of all-cause hospitalization with adjusted hazard ratio of 0.73. Also, lower rate of hospitalization for Crohn disease without surgery with adjusted hazard ratio of 0.58. Moreover, also lower rate of hospitalization for infection with adjusted hazard ratio of 0.56, as highlighted. Moreover, there was a numerical trend downward towards the lower surgical hospitalization for Crohn disease among Ustekinumab new users. However, the confidence interval overlapped the null value. Authors also observed no statistically significant difference in hospitalization for thromboembolic event, as you can see by the green arrows. So with regards to discussion, in this rigorous pharmacoepidemiologic study, authors compared the effectiveness and the safety of Ustekinumab versus Vedolizumab among anti-TNF experienced patients with Crohn disease in a large, geographically diverse, and real-world population, which showed no difference in treatment persistence rates beyond 52 weeks. Although the secondary outcomes such as all-cause hospitalization, non-surgical Crohn disease hospitalization, and hospitalization for infection favored Ustekinumab initiation. Considering study findings in conjunction with other recent studies, the emerging literature doesn't consistently support one treatment over other. Therefore, authors advocate for individualized decision. In this medically refractory population, considering preference and the factors like cost and the route of administration, Several recent European studies have sought to compare Vedolizumab with Ustekinumab, however, evidence to date remains inconclusive. A recent meta-analysis concluded that both treatments were equally effective in induction of remission, but Ustekinumab was associated with the better one-year outcomes of clinical remission, steroid-free remission, and biomarker normalization. With regards to the strength of this study, several studies were conducted in Europe. However, data from the US was scarce. Hence, this study provides real-world evidence about patients taken care in a variety of practice settings here in US. Moreover, this study involved large and geographically diverse population, allowing for generation of real-world evidence. Furthermore, this study involved rigorous pharmacoepidemiological study design to minimize the bias and control for confounding. As the limitations are concerned, as with any other study that relies on health insurance claims data, there is always the possibility of misclassification. However, by requiring several diagnosis codes for Crohn's disease along with the treatment codes for anti-TNF inhibitor and either Ustekinumab or Vedolizumab, and by excluding the patients with concomitant diagnosis of ulcerative colitis, authors do not expect significant bias. An additional limitation is that claims data lack clinical details such as Crohn's disease phenotype, severity, and lifestyle factors such as smoking status, though authors were able to adjust for a number of factors related to comorbidities, healthcare utilization, surrogate markers of the disease activity such as anemia and malnutrition. They recognize the possibility of unmeasured confounding. Moreover, this study included commercially insured adults continuously enrolled in the health plans in the US, hence limiting the generalizability to low-income patients like without insurance or insured by Medicaid, or older patients who have the Medicare insurance, and the children. So in this last slide, I would like to talk about conclusion and highlight the take-home points. What is known is that many patients with the Crohn disease lose response or become intolerant to anti-TNF therapy, and the subsequent treatment options include Ustekinumab and Vedolizumab. However, there is a paucity of research comparing the effectiveness of these treatment regimens in anti-TNF experienced patients with the Crohn disease, and existing studies have yielded contradictory results. What is new in this study is that authors compared the effectiveness and the safety of Ustekinumab to Vedolizumab in a large, geographically diverse US population and found no difference in the primary outcome of treatment persistence beyond 1 year. With regards to the secondary outcome of all-cause hospitalization, non-surgical Crohn disease hospitalization, hospitalization for infection, which favored Ustekinumab initiation, and authors advocate for individualized decision-making in this medically refractory population. In the end, I would like to thank you all for your attention, and I would be happy to take any question.